Dear colleagues, I would like to present you a long-term result of autologous transplantation of RPE and choroid for submacular hemorrhage secondary to CNV. The rationale of surgery is to save a healthy fovea by removing the altered RPE and choroid and transplanting new healthy RPE in the subfoveal area. The best indications are exudative detachments secondary to subfoveal CNV with external limiting membrane or ellipsoid zone still visible. The submacular hemorrhage secondary to CNV is the best indication. This is an example of good case selection. You see a CNV under a retina with external limiting membrane still visible. This is another example of good case selection of a submacular hemorrhage extended to the posterior pole secondary to CNV. These are my main publications, the technique and the long-term results. After an extensive vitrectomy, the retina is detached by injecting VSS through a 41 gauge needle in order to detach the whole temporal retina. Then the retina is cut through a peripheral retinotomy. In this case, it was performed with a 20G and scissor. The retinotomy can also be completed with the vitrectomy probe, and in this case I suggest to stabilize the retina with PFCL. The CNV is removed and the bleeding feeder vessel, which is always present, is closed with diathermy. And then a full thickness patch of RPE and choroid is transferred under the fovea. It is very important to center very well the patch. It is also important to take care of the edges of the patch, flattening them with the forceps. Then the retina is reattached by placing PFCL in the pre-retinal space, which is then exchanged with long-term tamponade, usually silicone oil 1000. 2 months after surgery, the pigmentation of the patch is always darker than the surrounding choroid. This is a case of subfoveal CNV with a very good looking retina on top. Please note the good visibility of the external layers preoperatively over the CNV and the good maintenance of the retinal layers postoperatively with progressive improvement in vision. This is the same case preoperatively and after 5 years. I recently checked the same patient 10 years postoperatively. She is 0.6 far vision and reading J1. She developed a CNV in the other eye. 77 years of age, who had been treated with anti-VEGF, and then she developed a massive subretinal hemorrhage. Vision was counting fingers. The same patient 1 week after surgery, vision was 0.2. This is the same patient 1 month after surgery. Vision is now 0.4 with a very well vascularized patch, and there is good correspondence with microperimetry. You can see she has sensitivity all over the patch area. And this is in B scan. You see a very good looking retina on top of the patch of choroid and RPE. She has retained a great vision for 4 years and she is now 0.5 and reading. These are my data since 2007. I operated more than 300 eyes and 88 of them have complete data and at least 2 years follow-up. They have been published. 23 eyes had hemorrhagic CNV. In the whole group, they were the ones with the most significant improvement in vision. The reading ability is reached in 40% of the patient. The eyes that improve keep improving in time. So this patient has a great microperimetry. Only 1/4 of the patch in the inferior temporal quadrant has no sensitivity, and it's due to the absence of the external retina visible in the B scan. I'm following the patient with angio-OCT, which shows the vascularization of the patch significantly enough. This is a patient 9 years postoperatively, vision is 0.8 and reading. This is another patient 5 years after surgery, vision is 0.5 and reading. We might have in 11% of the patients retinal detachment with or without PVR, and they need, of course, a new surgery. Much worse is the subretinal hemorrhage that I stopped having because I stopped operating patients with anticoagulant therapy. Macular hole, epiretinal membrane, recurrent CNV, and cystoid macular edema can have a surgical or a medical treatment. It's not about age because even older patients older than 80 years of age can have improvement in vision, both far and near. So we think it's most the status of health of the external retina at the moment. So now, would you advise a choroidal transplant to a patient of yours with a submacular hemorrhage? Thank you.